All right, welcome everybody. We're so excited to have you here for our last Future MDs in STEM winter camp session for the 2023 year. We're really excited to have Dr. Karen here as well, who's here to talk to us about her journey in medicine and just some advice that she has. So we'll go ahead and let her get started. Again, if you could please keep the chat for just questions about Future MDs in winter camp session for the 2023 year. We're really excited to have Dr. Okay, I think I got rid of my little echo. So if you could please just keep the chat for things that are only related to Dr. Karen's session, and then keep hands raised only for questions for Dr. Karen, that would be amazing. But we'll go ahead and let her get started.
All right, and I will say that I'm very happy to be here. I'm also really bad at looking at the chat. Can you see my screen?
Yes, you're good.
Great. So I'm really bad at looking at the chat while I present. So maybe feel free to enter your questions, and then at the end, we can go through them. If not, you can reach out to me at my email. And just because it is a long presentation, I've been doing this for a while, and I'm going to go through quickly. So I just wanted to talk a little bit about my life and how I ended up in medicine. The outline from the talk today is going to be talk about early experiences that kind of pointed me in the direction of medicine, why I ultimately chose a career in medicine, why I ended up in pediatric neurology, my career path since fellowship, and then what I'm doing now. And along the way, I'm going to throw in a lot of work-related travel experiences, because I think that's an important thing that's influenced me and that I contribute to the world. So starting early, I grew up in a very diverse neighborhood outside of Washington, D.C. in Northern Virginia. And I had friends from a lot of different cultures. I think this really influenced me, and you'll see kind of why later on. But I started taking Spanish in 8th grade and continued through high school. And I put a lot of effort into this. I'm not sure why I was so driven, but I did things like making my own dictionary. I translated and sang songs and practiced whenever I could. And this has really influenced my career path as well. I went to science and tech magnet school. That is a picture of a very failed science project there on erosion. But this continued to kind of nurture my interest in STEM topics. And I continued my Spanish there, took multiple AP courses, and I had a seminal experience volunteering to teach English to some custodians at our high school who were primarily Spanish speaking. And it got me exposed to kind of the immigrant experience, and really had an impression on me in terms of the challenges that population goes through in coming to a foreign country and all the challenges they have. So I got interested in neuroscience research early on in college. I went to Duke University, and initially my quest was to try and understand consciousness, because I thought that was important in terms of kind of my view on the meaning of life and all of that wonderful stuff. I was not interested in being a pre-med. I planned on being a neuroscience researcher, and I continued taking my Spanish courses and actually had a Spanish-speaking boyfriend, which is a great way to learn a foreign language if any of you have the opportunity. my junior year, I actually visited Mexico with my boyfriend. We stayed at his family in Mexico City, and that was my first travel experience outside of the US and Canada, and also had a great impression on me. So there was no such thing as a neuroscience major back then. So I did dual majors in biology and psychology with the concentration in the neuroscience. And I did research all throughout college, kind of over the summers on different programs, and then did my neuroscience research for a year full time after school. And ultimately decided that research was not a great fit for me. Research is kind of a delayed gratification thing where you put all this effort into your research and all this time, and then at the end you may or may not find anything interesting. And I'm more of an immediate gratification person, so it ended up just not being a great mix. By the way, it looks like there's 15 people in the waiting room. I don't know if they need to get moved in. So I didn't know what to do. I decided not to do research, but I didn't have a plan B. So I ended up moving to Denver and worked as a bicycle courier for most of a year while I applied to the Peace Corps. And I thought the Peace Corps would be a good way to kind of, clear the slate and try and figure out with an open mind what I wanted to do with my life. And I could help myself and other people at the same time. So I initially wanted to go someplace French speaking in the Peace Corps because I already spoke Spanish pretty well, but then I was offered a position in agroforestry in the Dominican Republic. They chose agroforestry because I had a major in biology and I had gardening experience, and also because I was a health reject. I'm allergic to sulfa drugs, and so apparently those people often get assigned to the Dominican Republic because they can be medevaced out. And honestly, I had no idea what I was getting into when I applied, but I was looking forward to an adventure. So if people know anything about the Dominican Republic, this is probably what they think: beautiful beaches and, it's the Caribbean climate and that sort of thing. But my experience was very different. I initially was assigned to work with some cattle farmers in multiple cities. These were cattle farmers all with 50 plus heads of cattle. And for those of you who lived in a resource poor country, you'll know that cows are expensive, and in the DR, they really were kind of your savings bank. So if somebody had 50 head of cattle, like, they were doing quite well by Dominican standards. And that was not where I wanted to work. And so I ended up in this small village, a small farming village called El Cercado, which was about 200 people, men, women, and children. And it was an hour and a half ride on the back of a pickup truck from the closest town, which was San Jose de Ocoa. And I planned on teaching organic agriculture to them. And that's me at my house. And that's the view from my house and the fence around my house. So just to give you an idea of kind of the environment. It was very isolated. We're kind of in one of those valleys in the bottom picture. No electricity, no running water. That's a kitchen on the upper left picture, where you can see like kind of the cooking area. And that's also a picture of the kitchen on the right with it's separate from the house, and goats walking through, etc. So I lived on rice and beans for 2 years, and the bottom picture are víveres, which are like yucca and plantains and that sort of thing. And it was definitely a transition for me, but it had a really profound impact on my life. I made good friends there. I've gone back and visited probably 8 times since I left, 20 some years ago. And I really grew as a person, and it underscored to me kind of the importance of travel. And you'll get that message, I think, from the rest of my talk too. That's me on the lower right in the latrine that I dug for my house. It had not been used at that point. That was me setting it up. So as I mentioned, it was very isolated. This was back when there were no cell phones, there was no internet. So really the only way I communicated with my friends and family was by fax. And I really had to reinvent myself, because me being this neuroscience researcher from Duke University didn't mean anything to the people there. And I had to kind of decide who I was outside of my career up to that point. And I planned on teaching organic agriculture, but there wasn't a lot of interest in that. So I ended up shifting into community empowerment, which was very challenging because it's a very fatalistic and paternalistic culture. I was kind of regarded by the other Peace Corps volunteers as a super volunteer because I was very active, like many of us are. We developed a tree nursery and planted about 2,000 trees. We got the local school extended from 4th to 5th grade. We fixed the drinking water aqueduct. That's the picture there is the community working to fix the drinking water aqueduct, established a local clinic, yada, 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 did a lot of stuff. And this is just a picture of the women at my crochet club. I taught a lot of women how to crochet to kind of have something that they could do that could earn money to kind of help them with their independence. So that was a lot of fun. And this is the clinic that we established, and it was in one of the rooms off the side of the school. People look serious there. That's just because it's a Dominican thing. They're actually quite happy. So I had some really profound health-related experiences while I was there. So one was watching a man essentially die from complications of liver disease, and I didn't know what it was at that time because I still hadn't had any health experience, but he had gone to kind of the local shaman and waited until the last minute to go to see the Western medicine doctor, and it was kind of too late to save him. And so just seeing kind of the impact that a lack of access to healthcare had on people. And then the picture on the right is of a little girl who had just an eye infection. This was just a viral eye infection, and it basically took out the whole village, because not from a mortality standpoint, but like everybody stayed in their houses. Nobody could get work done because they were so sensitive to light, and just, again, underscoring kind of access to healthcare. And I also did some medical translating for a group of ENT surgeons who came down and did cleft lip and palate repair and burn scar contracture release and that sort of thing. And it really made me think, like, how could I better spend 2 hours of my life than giving a new life to a child? And so these experiences kind of combined to make me decide to go into medicine. So that was a very daunting decision. As you guys know, applying to med school is very involved and very intimidating. I had to study for the MCATs and take them. And I had been out of school for 4.5 years at this point. So, it was a task trying to get my brain back into the learning mode. All the essays, the letter of recommendations, so many forms, it was a 1.5 year long process, and it was very intimidating. But the good news is that I had what it takes to get into med school, because I went to good schools, I had good grades, I had research experience and the Peace Corps. And so I was quite fortunate to have my choice of medical schools. After Peace Corps, I moved to San Diego as I studied for MCATs and applied for medical schools. I thought it would be a good place to transition from the DR back to the US, and I wanted to get California residency because I was thinking about going to UCSF. While I was there, I did neuropharmacology research at Scripps. We were looking at anhedonia, which is kind of a loss of pleasure in rats that were going through tobacco withdrawal. It was actually a fascinating study. And I took the MCATs and applied to med school. And I ended up going to UCSF after all. While I was there, I taught Spanish, medical Spanish, to my classmates and organized a Latino health elective. And for the Spanish classes, I actually won a very prestigious award. We had a lot of students and faculty who were interested in taking the course. At that point, I wanted to go into primary care, just providing access to care versus possibly surgery for cleft lip palates. But primary care felt very assembly line. It seemed like it was just every 10 minutes another patient, and you didn't have time for any particular patient to really establish a relationship. And I don't know, it just wasn't a good fit. And I had no idea what I really wanted to do, but I knew that I didn't want to do pediatrics and I didn't want to do neurology. While I was in med school, I also helped found the GPPCI, which is a primary care initiative that's international. And I got to spend a month in South Africa and Swaziland, where I was doing research on kind of the brain drain and all the doctors that leave after they get educated. And this was supported by a couple preceptorships and funds and travel awards. And ultimately, I ended up in peds neuro, to my surprise. And, I've always had interested in neuro. I thought it was fascinating. I think the reason that I didn't want to go into it initially was because I thought of neurology as being adult neurology, which is a lot of, stroke and dementia and things that to me were really depressing. But it turns out that pediatric neurology was quite different, and there's a lot of things you can really do to turn people's lives around. Kids are fun. You get hugs, you get to make jokes and wear whatever you want. And, kids' hospitals are bright and colorful, and it just worked with me. And then peds neuro kind of got to my passions about access to medicine, because it's an area where there's a real shortage of providers. So I would be making a difference in the world by going into this specialty. And for personal benefits, it meant that I could get a job pretty much anywhere I wanted. So I ended up doing my residency at the Mayo Clinic in Minnesota because I had two nieces up there and I wanted to be close to them. That's my little house on the right, my first house. Mayo is in Rochester, Minnesota, which is a population of just about 70,000 at that time. And it was ridiculously cold. And it was a great experience, but it was very challenging for me. I actually had some seasonal affective disorders and, lots of self-doubt and that sort of thing, which I think is common among people in medicine. But I did well. I was able to continue my travels while I was there. I actually spent a month in Malawi doing a rotation at a pediatric HIV clinic that was supported by a program at Mayo on international health. And that's a picture of basically a local witch doctor on the right selling his wares, his medicine on the street. Malawi, seeing kind of medicine and how medicine is in resource poor countries was impressive. You don't really get that much of a sense of it, but it was just one bed lined up next to the other in a big, a huge room, and rounds consisted of a doctor, talking to residents and spending 5 minutes on a patient and then moving on to the next bed. And the picture on the right is of those are ambulances in Malawi. While I was there, I got to volunteer at the local children's hospital. Lots of malnutrition, lots of undiagnosed neurologic problems. I wasn't there. I didn't have my medical degree, or I didn't have my fellowship, and I wasn't, authorized to do any medical training, but I tried to work as a patient advocate, especially for kids with neurologic symptoms, and try and get imaging and that sort of thing. And it was just very moving. And of course, I took advantage to go on safari while I was there. It was great. I saw lots of animals. This was just a herd of elephants that decided to walk through our camp. So you can see there I am inside my little hut, and there's an elephant right outside. It was quite exhilarating. So I did well from kind of an academic perspective while I was at Mayo, and won this big award, which was a shock to me because like I said, I had a lot of self-doubt at the time. One benefit of this award was that I got funds to travel to attend a neuroscience conference in Sydney, Australia. I had never been to Australia before. It was really quite fascinating, and that's the Sydney Opera House on the lower right. Took time, taking a road trip along the coast. And again, sorry to be going through these pictures so quickly, but I just have a lot to talk to. And then I did a tour kind of in the desert, the Red Desert, and went and saw Uluru. And yeah, it was just a new experience for me. I ultimately decided to take an epilepsy fellowship. This was due to a lot of reasons. One was that I didn't really feel ready to be the doctor yet. It just didn't feel like I was right there. I also wanted to learn a subspecialty because the way my brain works, I don't have great long-term memory. So, another reason that being a primary care doctor where you might not see something for 6 months and then you have to remember what to do with it, that would be hard for me. But being in a subspecialty, I see kind of the same flavor of patients regularly, so it helps with kind of my particular brain. I thought of reading EEGs. That's a picture of an EEG on the right. It's kind of like speaking a foreign language. I can look at a bunch of squiggly lines and get a story from it, whereas to most people it just looks like squiggly lines. And I also had learned that procedures are power. And what I mean by that is that procedures are reimbursed much better than clinic visits. So I can read an EEG and make more money off of it than in like 5-10 minutes than I can spending an hour with the patient, just because of the way healthcare works in this country. And so you have a lot more power in terms of how you spend your time when you can be financially productive for your employers. So it seemed like it was a great fit for me. So I did a 2-year epilepsy fellowship at Children's Hospital of Philadelphia. I love living in Philadelphia. And while I was there, I submitted an abstract to the International Epilepsy Congress that was being presented in Rome. And I was actually selected to present my data at a platform and won a travel bursary that covered airfare and hotel costs. And that's me giving my little presentation there and me with a friend of mine. Of course, if you're in Rome, you have to go and see all the incredible historical buildings and sculptures. You have to go to the Vatican and see the crazy art. That was impressive. And then after my fellowship, I ended up taking a position as an assistant professor in Louisville, Kentucky. I didn't have any ties to Louisville, growing up, but 2 of my 4 nieces had ended up in Kentucky, and I wanted to be close to them. That's my second house there on the right. While I was in Louisville, I was there for about 7 years, and I was able to do a lot of travel. So this was a conference in Ecuador that was sponsored by the American Academy of Neurology. And I gave some presentations there at a local hospital. Just a beautiful, beautiful hospital. There you can see on the left from kind of an aesthetic standpoint. But again, very primitive in terms of, just rows of beds lined up in a big room. And you can see a wheelchair there on the lower left. So these are just pictures of Ecuador. They had iguanas all over the place, which I thought was fun. And since I was in Ecuador, I had to go to the Galapagos, which are just off the coast of Ecuador. That's me kissing a statue of Charles Darwin. Lots of animals that are unique and interesting and not afraid of humans in Galapagos. So definitely a new experience. Did some scuba diving, which I love. I also went to Sudan. I joined the International Child Neurology Association and began giving lectures at international conferences. So in February 25th, I went to Khartoum in Sudan. That was a great experience, really the first time I had spent any significant time in a Muslim country, which was just, it was a new experience. So that was the conference, and I gave some lectures regionally as well. There's another hospital on the left, and I believe that was a group of nurses on the right, but it's been a while, so I gave some lectures at local centers. Just really great experiences with patients and their families. And of course, I was in Sudan, so I had to go visit Egypt, and I got to see the pyramids and the Sphinx and did all sorts of traveling and more scuba diving. I also went to Turkey and Armenia later on for the International Epilepsy Congress in Istanbul. I got to visit some of my friends in Antalya and go scuba diving. And I'm actually a quarter Armenian, so I got to learn a little bit more about my heritage. These are just some pictures of Turkey. This is one of the mosques there. I liked there's this huge praying area for the men that's, just dramatic and beautiful. And then there's this little side area that was women's praying, the women's praying area. So a little bit different. I went back to Ecuador to give some more lectures in 2017. This time it was in Guayaquil, which is a different part of Ecuador from where I had been before. I got to visit Quito, just gave some more talks and took in the sites. I ended up giving contributing at a conference in Paraguay through the International Child Neurology Association. Just some pictures of my presentations, made a lot more friends. Got to spend some time for travel as well. I went to India, to Kerala in India, and for another program, and gave some more lectures. These are just some interesting pictures. I love the one on the left, do not wash your feet in the sink. These are actually from, I think the picture on the right is from Paraguay, but no, I think it was from India. I thought it was great, Libido Agua. It was just water, that was just the brand name. It was great. In India, they have these taxis that are called tuk-tuks, and they just reminded me very much of Angry Birds. I thought it was the funniest thing. More pictures of Kerala, which is on the coast. Just a wonderful experience. There's a little, quite a difference from US where, we've got child seats and everybody needs car seats and stuff. And here's this mom just carrying her daughter on her lap as she sits on the back of a motorcycle. So a little bit different. Some more pictures. I went to like an elephant orphanage and watched them bathe the elephants. And then shortly after, I actually went back to India for the annual ICNA conference in Mumbai. Took advantage of the time to do the Golden Triangle. So just some beautiful, beautiful sights and cultural experiences. This was our guide's shoes. I love them. I tried to find them, but I couldn't. Beautiful. And that was a bus that went by that had like tons of people just sitting on the top. I was like, that's not safe. Lots of pictures of interesting people watching from the car. We saw camels, and that is a swastika on the camel, but it has nothing to do with the Nazis. I don't remember what it means, but it was kind of a shock to see it. Some great travel experiences. Went to the Taj Mahal, of course, which was magical. Had some fun with elephants and went to the conference in Mumbai. Went to one of the hospitals there. You're starting to see a theme there. This was the area outside the NICU where everybody had to take their shoes off to go in. And did a motorcycle tour around Mumbai at night, which was fun. So in 2019, I had the opportunity to move to Texas to take a position there. That's my house. Oh my God, I loved it. It just, we were close to everything, but it felt like we were in the middle of the woods. It was just fantastic. I took a position there as the director of clinical neurophysiology. That's my office. Me on the right with the patient, I'm the skull. I love that outfit because it's actually an X-ray, like a full body X-ray. So it seemed like a medical one. I went to Kenya to volunteer at a pediatric epilepsy clinic, and I took my second oldest niece with me, Josie. And this is just a picture of people getting registered for the clinic. And on the right, that's a social worker who worked as my translator, my interpreter while I was there. That's the clinic where I saw patients on the left. My niece Josie kind of playing with one of the patients, and the upper right, you could see it was, that was my name, was Dr. One. went to another elephant orphanage and just had some great elephant experiences. They are very intelligent creatures if you've never had the opportunity. Did some cultural things and did some glamping. Went on safari, saw cheetahs up quite close, lions. Oops, this slide is out of place. That's me moving from Louisville to Texas. So about 50,000 kids in Texas have epilepsy, often with daily or weekly seizures that can result in injury, hospitalization, and death. And there's been significant disparities in care and outcomes documented in Hispanic and limited English proficient or LEP populations, which were about 30 and 10% of the population of Central Texas, respectively. I realized that the NIH designated health disparity populations did not actually include populations with limited English proficiency, which I thought was a real oversight on their part. Basically, the research shows that Hispanic and LEP patients with epilepsy, both in adult and pediatrics, are less likely than non-Hispanic whites to actually receive anti-epileptic drugs, to achieve seizure control, to undergo surgical treatment, which is the only curative treatment for epilepsy. There were a lot of potential factors that probably contributed to these disparities, including decreased access to care, communication barriers, and decreased trust between patient and provider. In 2019, I got the idea for a pediatric epilepsy Spanish clinic, which was going to be an immersive, kind of welcoming environment for Spanish-speaking families with limited English proficiency. And there I did research in health disparities and inequities. So there were two goals of the clinic. One was to provide the clinic to benefit local patients, and then also to gain research to kind of understand the underlying factors contributing to these disparities to benefit patients nationally. I got this $80,000 grant for costs. I ended up using very little of that, but we did get tablets and for patients to fill out their questionnaires on, and some statistics help. Most of the work was done by undergraduate volunteers. They set up the REDCap database and administered questionnaires at 5 different sites throughout the weeks. I submitted the proposal to the IRB, it got approved, and we started collecting data. And this is just an example of some of the data that we collected. So a comorbidity is kind of an associated disease. So for epilepsy, comorbidities include like learning disabilities, ADHD, mood disorders, behavior disorders, sleep disorders. And what we found is that if you look at the likelihood of having their comorbidities documented, they were relatively high in white, non-Hispanic English fluent patients, Hispanic English fluent patients, limited English proficient patients with language concordant providers, so meaning the providers spoke Spanish. But there was a markedly lower rate of comorbidity documentation when the LEP patients were seen by a language discordant provider through an interpreter. And oops, that got formatted funny when I copied it, but the referral frequency kind of mimicked this. So basically, we did a good job. If we spoke the same language as our patients, we did a good job referring out for things like psychiatry, psychology, neuropsychology, PTOT, speech therapy, that sort of thing. But the LEP patients with language discordant providers were not getting referred out for the services that they need. So while I was in Austin, we saw some patients from El Paso, and I was very confused about why we were seeing them there, because El Paso is about 8.5 hours away from Austin by car. And I actually had suggested that we do a satellite clinic there, but there wasn't a lot of interest. The it was just this physician desert in El Paso. So these are all the pediatric neurology and pediatric epilepsy providers in Austin. And there were like 40 some. And in El Paso, there was one, and El Paso is about half the size of Austin. So there should have been about 20, relatively speaking, but there was one person there versus 43 in Austin. So I realized I needed to go to El Paso. So I left academia. I'm trying to check the time here. Where's my phone? But I left academia and opened a private clinic. It's the El Paso Center for Seizures and Epilepsy. And our goal is to be accessible. So we accept Medicaid, TRICARE, private insurance. If you're uninsured, we have very low prices. We do a sliding scale for people 200% below the federal poverty limit, and do payment plans. And we have evening and weekend hours. And sorry, my cats are fighting. And I staff the clinic entirely with pre-med students in their gap year. They help me set it up, the clinic up. They work in the clinic and do pretty much everything in the clinic, from front office, MA, EEG tech, back office. They do everything. And so what do? I see new patient consultations. I do routine EEGs and ambulatory EEGs. And then I'm continuing with my health disparities research. So we've been open for 7 months now. And I have 5 pre-med students as staff. There are 3 student volunteers working on the research. Our clinic schedule is already full after 7 months. I do reading for EEGs at local hospitals, and I'm working to open a free clinic in Juarez, Mexico. I'm actually having to look for a partner. We've gotten so busy. So my take-home points are, number 1, look for opportunities to travel and find funding through grants, research, etc. These are just a list of some of the grants that I received to do my research and travel. There's a ton out there, so take advantage of it. Number 2 is don't be just another doctor. Find a specialty where you can make a difference. If there's a ton of ophthalmologists in a particular area, don't be another ophthalmologist. Instead, sorry, my cats are playing. Instead of being just another doctor, like, find a specialty that's in shortage, and you'll make a huge difference. Look for opportunities abroad and at home to make a difference and make an impact, and share your experiences with others. And when you can, take people with you. I brought my nieces with me when I traveled because I wanted them to see life outside of the US. The US is kind of a bubble, and the majority of the rest of the world don't have a lot of the privileges and resources that we have. And so I wanted them to kind of understand what life is like outside of the US. And then finally, lend a hand to help someone take a step up. This is Tabitha. If you recall, she worked as my interpreter when I was in Kenya. I'm actually helping her to come out to the US to study nursing at one of the schools here. And so, let your experiences impact you, and don't forget them, and try to help others when you have the opportunity, because really we should be grateful for everything, all of the benefits that we just happen to be born into by being born in this country. So, and then finally, be the change you wish to see in the world. And I think that is it. I'm happy to take any questions.
Awesome. So if you have a question, you're more than welcome to raise your hand on Zoom, or perhaps type it in the chat, and then Dr. Karen can call on whoever she'd like to.
Okay, I'll just call on people with hands first. So Afnan? Unmute. Yeah.
How are you?
Good. How are you?
I'm good. So I actually had sort of 2 questions. My first one was, I know you're a pediatric neurologist, so I was wondering if that's like a subspecialty within pediatrics, or is it just like one specialty?
So it can be considered a subspecialty inside pediatrics or inside neurology. But it has its own residency. It's like a combined residency where you do pediatrics and first you do 2 years of pediatrics, then you do a year of adult neurology, and then 2 years of pediatric neurology.
So it's a lot longer.
It's actually shorter than if you do pediatrics and then another fellowship, because that's usually 6 years. So this is 5 years total.
Okay. And then my other question was, I know you mentioned you did a lot of research in college and after college too, and that was kind of like a booster when you applied to medical school. But what if, let's say, like, I'm not really interested in research? Would that be like a negative impact?
Well, there's a ton of different kinds of research. So there's basic research where you're in a lab and you're working with test tubes, and there's translational research where you're working with animal models of human diseases, and then there's clinical research where you're just working with people. So I think it's good to get experience in one of those areas because it helps you understand medicine better and helps you be a more critical reader when you read papers and try to make decisions about your patients.
Okay, thank you.
Yeah, no problem. Farha Reda. Farha?
Hi,
Hi.
I'm Farha and I am from Egypt. I am 16 years old and I study in STEAM schools. I am in grade 10. So I'd like to study medicine. So please give me some advice.
Some advice on what? I'm sorry.
Some advice because I'd like to study medicine.
To study medicine? Well, I think, you
Yes.
know, my presentation was a good summary of some advice, which is, you know, try to get some research experience, get some travel experience. And these days, you really need some clinical experience too, to try. And all of those things, along with good grades, good MCATs, will help you get into medical school.
Okay, thank you.
No problem. Rama?
Hi.
Hello.
First question, how can I study abroad many times like you?
How did I do it, or why did I do it?
Both of them.
How is, as I mentioned, I got a lot of different scholarships that supported me to travel abroad. These scholarships are out there. You just need to find them and apply. And I did it because to me, I think, as I mentioned, you know, in the US, we're in this little bubble of resources and opportunities. And to me, you know, a lot of the world outside the US doesn't have those same opportunities. And so I wanted to educate myself. I wanted to help people, and it's just fun. So
Inspiring person.
say that again.
You are an inspiring person.
Oh, thank you so much.
So the second question, is English necessary to studying abroad? And if it...
Where are you from?
I'm from Egypt.
Also from Egypt. So it depends on where you're going to study, right? But I can tell you that most of the countries that I've traveled to, the doctors do speak English in addition to their local language.
So if I improve my English, is it will be enough to studying in Germany?
So will your English be good enough to study in Germany?
I'll improve it.
Yeah, I think practice and try some of the things that I mentioned I did with Spanish, you know, like don't just take the course, really dive in and practice whenever you can. And I'm sure you'll do well.
Okay, thanks.
No problem. Gabriella?
Hello, can you please explain again the comorbidity thing that you were talking about? Because I kind of didn't understand it that well.
So a comorbidity is an associated disease. So I'm an epilepsy specialist, and a lot of kids with epilepsy have other conditions like ADHD or mood disorders like anxiety and depression, or learning disorders or sleep disorders. And so what I was looking at is, well, if I'm an epileptologist and all I do is talk about seizures and side effects from medications, then I'm not really doing a good job with my patients, because I also need to talk about all these other associated problems that they have and make sure that they get referred out to specialists. And so what we found is that when a patient was seen by a provider who didn't speak their language, they weren't asking about comorbidities and they weren't sending them for referrals. So it really impacted the care we were providing.
Okay, thank you. That really helped.
I'm not sure how to pronounce your name. Allah Hani El Wakil. I think you're muted. Go ahead. Okay, there we go.
A question, is it easy to have a scholarship in a medical school outside Egypt? Or
So I would say that well, you mean like a scholarship to go to medical school?
yes, outside Egypt.
I don't know the answer to that, because I didn't apply, but I think there are things you can do to make yourself more attractive for scholarships, and those are things like research and clinical experience, and all those things that I mentioned in my presentation are things you can do to make yourself more attractive to get a scholarship.
Okay, thank you.
No problem. Ahmed?
Hello.
Hello.
I want to ask. I have some interest in neuroscience field, and I want to work in it in the future. Do you have any suggestions for me to increase my knowledge in this field?
So I would try to, certainly read, get like a basic neuroscience textbook and educate yourself. But then also find, a subject that you're interested in and look up to find who's doing research in those areas. And then you can reach out to them and perhaps help do their research. So, but I would say, read and then look to the literature. You can go to sites like PubMed, PUBMED.gov, G-O-V, and do research, to find out who's working in areas that you're interested in, and see if, there's any opportunity you can get involved.
Okay, thanks.
You're welcome. Shahid Debiat?
Yeah, actually, you pronounced it right. Hi, hello.
Hi.
So basically, we're currently living in a speeding era. Artificial intelligence is replacing a lot of the roles of doctors, if we can kind of a bit tell about that. So from your perspective, from your experience, comparing between neurobiology and neuroscience, which major has the most opportunities and most horizons open for it, and has like new developments and for the long term and future? So in your experience.
So I did work in a neurobiology lab briefly. They're very related. Neurobiology is just a little bit more medical oriented, but I think either of them would provide great experience for research and for a career in either resource or medicine. And as for your comment about AI, I can tell you that I will never be replaced by artificial intelligence, because you would have to enter in so much information about the patient in order for there to be any sort of a logical conclusion about patient care. You know, there's really, they say medicine is as much art as it is science. And I feel like, you know, in my subspecialty, it would be very hard to replace a doctor with a computer. And then they've been trying to get programs to be able to interpret EEGs for decades now, and it's just very hard to do. Nobody's been able to accomplish it yet. So I feel pretty safe in my career.
Oh, honestly, I rephrased my question in a bad way. That wasn't actually the message that I want you to receive. Basically, it's not replacing. The word is heading now more towards the information technology development. You can see it actually. And actually, I don't know if you can share this, but doctors like have been like afraid of this information technology development. Like just like an answer, a short answer, please. Like, do you find that neuroscience has like open horizons, open opportunities for you to excel and actually like develop new things in neuroscience as much as neurobiology? Because if we talk neurobiology, it's kind of is it the dominant more than neuroscience?
I wouldn't say that it's more dominant, and please forgive my cat in the background. I think there's opportunities in both of them. If you're interested in both IT and neuroscience, I suggest you check out cognitive neuroscience because there's a lot of IT opportunities there.
Okay. Thank you so much.
No problem. Amina Lotfi?
Yeah, hi. I admire your adventures, and I want to ask you which country did you like most?
Haha. I can't answer that. I enjoyed all of my experiences.
Okay, thanks a lot. Your story is very inspiring.
Thank you. Mayar? Or Mahar?
Hi.
I'm not sure. Hi.
First, you are amazing person, really. I wanted to ask you, you got a lot of adventure in your life. So I wanted to ask you how you be accepted in a lot of scholarship. Like, can you give me some advice to be accepted in scholarship?
So definitely you want to get into the best college you can, and you want to get good grades. And then you just need to apply, apply, write good essays about why you're a good fit for that particular scholarship. And if you get turned down from one, don't get discouraged. There's a lot out there, so just keep trying.
Okay, and the next question, I am from Egypt, okay? So I wanted to study medicine in abroad. So are you thinking study medicine in abroad is a good choice for me or not?
So study medicine and above?
Yeah.
So I don't really know what the opportunities are to study medicine in Egypt versus abroad. But I think that, just go to a reputable medical school. If you can come to the States to study, I think that's great. If you want to come to the States, definitely do it before you do your residency, because if you try to come to the States after completing your residency, you'll have to repeat it. So come as a med student, and then or come as a resident, one of those two things.
Okay, now I am in grade 11, okay? So what can I do to improve my skill in medical field? To be able to join medicine college?
So I think, try to join any clubs or get any experience that you can in the medical field. Certainly med schools like it if you have some experience. Go to your local hospital and see if they need any volunteers. Ask your doctor if there's anything you can do in his clinic to help. So just try and get some experiences. And then, of course, do your best in school and get the best grades you can, and, join clubs that you can that have similar interests.
Okay, thank you.
No problem. Ilias?
Hi, how are you?
I'm good. Thank you.
I just want to ask you that, did speaking several languages help you to, in your volunteer experience worldwide?
Yeah, I give a lot of my talks in Spanish. So when I go to a Spanish speaking country and give a medical talk, I give it in Spanish. So that's very helpful. I think, when you speak different languages, it just opens up additional travel opportunities. And, just like my research showed, you take better care of your patients when you can speak their language.
So I have another question. So in here in Morocco, we study medicine in French. So you can't go to another country and practice medicine because of the language of teaching the medicine. Is it a big problem, or can I is there something that I can do after graduation so I can travel and work in an English speaking country?
Well, your English is quite good. You're very easy to understand. So I think just keep working on your English. And I will say I've also been to Morocco. I didn't put it in my presentation because it wasn't medicine related. It was just for fun, but you have a very fascinating and beautiful country.
Thank you, and I hope you enjoyed your time here.
Thank you. Rawan Ahmed.
Okay, hi.
Hello.
Okay, at first I want to inform you that the presentation was really wonderful and inspired me in some ways because I'm really into neuroscience and I'm interested in getting in a career direction that it's really related to neuroscience research, especially. And I was amazed when you mentioned that you're researching at first out consciousness because it's one of the biggest problems that are not solved in neuroscience till now, I guess. And I wanted to ask you, how can I start or involve myself in research earlier so I can find many research opportunities, even if I'm not interested at treating patients directly, and I'm interested in doing research in labs and finding methods that can help me invent something that is added so doctors can use it. Do you understand what I?
Yeah, I think so. So I would say I would repeat some of the advice that I gave earlier, which is since you have an area that you're interested in, go to pubmed.gov. So that's PUBMED.gov and find pub like publish, med like medicine, that's all one word, .gov, and try and find a researcher or researchers who are doing research related to what you're interested in, and then reach out to them and see if there's any way you can get involved.
Okay, thank you so much.
No problem.
We have time for 2 more questions.
Okay. Rowan? Oh, that was Rowan. Allah Khaled. Okay. Mariam Mishael.
Hello.
Hello.
I want to do a lot of things like you, but I'm afraid to take a step that I might fail.
I'm having real trouble understanding you. Your audio is not very good. Can you try and see if you can make it clearer?
It's like you, but I'm afraid to take a step that I might fail.
Say that again.
I want to do a lot of things like you, but I'm afraid to take a step that I might fail.
Oh, all of us have that fear. So it took me a long time to really get the confidence in myself. So just do it. Just do it and do your best. There's a phrase, fake it till you make it. So the idea is even if you're not sure of yourself, just go through the motions and eventually you'll get there.
Thank you for your advice.
Sure. Yosef Mohammed?
داخله قسم باللابتوب ما لقيتش لما خلصت الفيديو بتاع محمود عبد الله لقيت
I'm not sure who that was, but all right. I think that's probably the time that we have, but it's been wonderful to be here with you guys. And
hello, can I ask you a question?
I think that we are out of time. We're past the hour. So and I was kind of going in order of the hands. So thank you all for being here today.
Thank you very much for your big.
I wish you all the best of luck.
Sorry about that. You can go. I think
Thank you for playing us
by accident. So I'll try. I'm working on trying to meet people. Okay. Alrighty. If our guest speaker is still here.
I had question. She's leaves. Yeah, it's okay.
I think our guest speaker left, but an option to send her a thank you message will be on that form that we released to you earlier. So if you want to send her a thank you message for coming to speak to us today, that we really appreciate it. And you also get volunteer hours for that as well. So we really recommend, submitting notes, saying thank you to our guest speakers, etc. That would be wonderful. And before we transition into our workshop segment of the session today, we will be taking a group picture. So if you'd be comfortable just turning your cameras on for like 20 to 30 seconds max, that would be wonderful. You do not have to keep it on for the whole session, of course, just for the group picture. And then I also have to remember to turn off my closed captioning because otherwise it blocks out some people's cameras. So let me just hide those. I'll give everybody a minute, to fix your hair, do whatever you need to do. And then I'll go ahead and take it. Again, we'd really recommend sending a thank you message to our guest speaker, especially since she had to leave at 12, so we weren't able to give her a virtual round of applause or to say thank you ourselves. So that would be wonderful. And then I'll give everybody like 20 more seconds. You could turn your cameras on now, and then I'll go ahead and take the picture. Again, you are not required to turn your camera on. You'll be fine if you don't, but we would love to see all of you. It's really nice seeing all of your beautiful faces. Okay. I see everybody fixing their hair. Love it.
لا مش عايز حاجة.
Okay. Okay, yeah, and no worries if you can't turn your camera on. Some people are messaging me saying that their cameras aren't working. No worries, again, not a requirement. Gonna lower the raised hands for right now, just because we're taking a group picture. And then I can take up a few questions before we move into our workshop, okay?
Hello, I have a problem to open the camera. It is not working. How can I do?
It's okay. You don't have to turn on your camera, okay?
Okay, thank you.
No worries. Yeah, not a requirement. Just if you can, we'd like you to, but you do not have to. Also, if you're not comfortable with it, that's totally okay. Alrighty. Okay, so I have to take a couple pictures because not everybody fits onto one screen for me. That's a wonderful problem to have. Oops. What is this? Give me one sec. Okay.
Please.
I think we're all set now. So I'll give everybody a little bit of a countdown and then just stay smiling maybe for like 10 seconds so I can take a couple of pictures in case anyone's blinking, and then also because everybody doesn't fit on my screen. Alrighty. Okay, I think we're good to go. Everyone good? Awesome. Okay, ready? 3, 2.
Wait, can you wait? Just a second.
Sure. I will wait a couple more seconds. Farha, is this urgent?
Hi.
Hi.
Is there any quiz or task for today's session?
Sorry?
Is there any quiz or task for today's session?
Please ask this question later. We're taking your picture right now.
Okay.
Thank you.
Hello.
Yeah.
What will we do now?
We're taking a group picture and then we'll be moving on to our segments.
Okay.
All righty. Okay, I'm gonna go ahead and just take the picture now. If you're unable to turn the camera on, that's okay. All righty. Okay. 3, 2, 1. Stay smiling. I haven't gotten everybody yet.
Please, can you wait a second?
Okay, one more.
Can
Okay.
you wait a second?
I can wait like 10 more seconds for you to turn your camera on, but then we do have to move on, okay?
Okay.
But you guys, you're all free. I think I got everybody. There's so many people that it took 3 screens, which is awesome, but I think I was able to get everybody. So I think all good. Eda, are you okay? Okay, I'm gonna wait a few more seconds and then you can go ahead and turn off the cameras. Okay. Okay, you can go ahead and turn off your cameras if you want. You can keep them on too if you'd like to keep them on for the session, but I know that that might be a lot. So you can go ahead and turn them off if you'd like to. It was wonderful seeing all of you, and thank you so much for turning your cameras on for our picture. We'll send all the pictures out to you at the end of the session. Alrighty. Okay, so now we'll be moving on to our workshop session for today, which is going to be run by Thanuja. So Thanuja, do you mind giving me a wave?
Can you wait for a second?
Hello.
Awesome.
Right here.
I'll go ahead and spotlight you.
Okay.
And then I'll go ahead and share my screen and then you can get started. Again, if people have questions about homework, which is going to be released at the end of the session, if you have questions about the case study competition, etc., all of those will be answered at the end of the session. We always stick around for a chunk of time after the sessions are done to answer all of your questions, okay? All right. I'll go ahead and share my screen and then we can get started. And just let me know when to move slides, okay?
Yeah.
Awesome.
Can I ask you some question?
What's your question?
When we will take a photo?
Hi, the photos already happened. Sorry. Okay, go ahead.
When we will take a photo?
Yeah, the photos already happened, but maybe if there's time at the end of the session, we can take another one if you missed it.
All right, are we good to get started?
You're good.
Okay, hi everyone. Thank you so much for joining us today on the final day of our winter camp. I hope you guys enjoyed and took something away from this camp, whether it's through our guest speakers or the workshops. So my name is Tanuja, and I'm one of the directors here at MedStem Powered. Also, I just want to say apologies in advance if I'm not looking directly at the camera. I have two devices going on here right now, so my presentation is up on another screen. But anyways, today's workshop is going to be more on the interactive side because you all have the opportunity to take on the role of a diagnostician by analyzing a patient's symptoms, past medical history, and lab results. And this will be a great preparation for the case study competition, which we highly recommend you all participate in. And if you missed yesterday's session, we will provide more information on Slack, and feel free to message one of us on Slack if you have any questions. And so, although today's case study, the cases we cover may not be as intricate as the case study competition, you can still apply the skills that you learned today to diagnose a patient and even propose a treatment plan. So moving on to the next slide, in order for a successful clinical diagnosis, it's very important to understand the steps that need to be taken when approaching a case. So the first step is to listen to a patient's past medical history. Give me 1 second. Just opening up my slides. So, patient's past medical history is very important as a patient can present symptoms of previous medical conditions. So, for example, if a patient who previously had a bowel surgery, they could develop an acute bowel obstruction because of adhesions produced by the past surgery. Listening to a patient's past medical history can also help us rule out possible diagnosis. And in addition to past medical histories, it's also important to have a thorough understanding of their family history and their social history. So a family history would mean, getting a record of health conditions in their family, as they can indicate genetic predispositions to certain diseases. And social history involves things like, what is their occupation? Are they a smoker? Do they travel a lot? Do they exercise regularly? And do they eat a healthy diet? Next slide. So the next skill is to listen to the presenting complaint. Instead of jumping ahead right away to pre-rehearse questions that we feel inclined to ask, it's important to listen to the patient first. So professionals use a patient-centered approach known as the ICE model. ICE is an acronym that stands for ideas, concerns, and expectations. So when it comes to ideas, this would mean asking the patient, what do you think is causing the problem? Concerns, do they have any particular worries? And expectations, what were they hoping to achieve from this visit? Next slide. In addition, we also want to listen to a patient's previous drug history. According to the National Institute for Health and Care Excellence, 6 to 7% of hospital admissions are due to adverse drug reactions. And listening to a drug history is also important when we're proposing a treatment plan, because we don't want to use medications that the patient could possibly be allergic to or had an adverse reaction to in the past. And it's always important to be aware of drug side effects, since they can be a powerful source of suffering as well. Next slide. In addition, it's also important to listen to carers, or as we like to say, key eyewitnesses. Because they've been with the patient a lot longer and they know the patient, they have very invaluable insights that could really help us in diagnosing the patient. And in addition to carers, obviously we also want to hear from other healthcare professionals, whether it's a patient's nurse, a healthcare assistant, or a therapist. And last but not least, switching over to the next slide. Thank you. Listen to what is not said. Evaluate the patient holistically. So what does this mean? A holistic diagnosis doesn't just mean, giving a patient's symptoms a name, but rather taking into consideration the physical, psychological, emotional, behavior, and social components of their health to determine the underlying cause. So I just want to ask you guys a question. So based on out of the 6 skills we mentioned, what was the most recurring or common theme you noticed for a clinical diagnosis? I can't see the chat here, so Davina, if you Let me know the answers. Yep, go ahead. Yes, exactly. Observe and listen. In fact, 80% of diagnosing a patient is actually through understanding their history, and only 20% is through examination. So listening is definitely the most important clinical skill. So we're going to move on to common diagnoses. So this list could go on forever, but we've narrowed it down to a few of the most common conditions that a patient may have when they're coming to a medical practitioner. So take a few seconds to read the bolded items on the screen. At first glance, I know some of these terms may seem very complicated and lengthy, and you may be wondering, how am I going to know all of these? But that's why we're going to be practicing the skill of breaking down these intimidating medical terms into simple prefixes and root words that we can understand. And once you understand these root words, you can apply it to any medical term. So starting off with hypertension, we can break that down into hyperintention. So does anyone know what the root hyper means? Feel free to type it in the chat.
We have some hands raised. I can call on some people if you'd like.
Sure.
Okay, Gabriella or Shema, either one.
Yes, I'm Shema. I guess hyper means high.
Yes, exactly. Hyper means high, excessive. And what does tension mean in medical terms?
Maybe blood pressure?
Yes. So when we put it together, we get high pressure. Moving on to hyperlipidemia. We can break this down into hyper, which we already know is high, lipid, and emia. So what does lipid mean? Fats. Yes, I see that in the chat. And emia. This might be a bit more tricky. In blood, exactly. So hyper is high, lipid is fat, and emia is the presence of something in the blood. So when we put it together, we get the presence of too much fat in the blood. Fibromyalgia. Does anyone know what the root fibro means?
I think Shams has their hand up.
Yeah, go ahead.
Oh, I think they just lowered it.
Oh, okay. So fibro refers to fibers. What does myo refer to? Muscles, exactly. And algia, does anyone know what algia means? Pain, exactly. So if we put this together, fiber, muscle, and pain, we get pain in the muscle fibers. Hypothyroidism. So we know that hyper means high. What does hypo mean? Too little, yes. And the thyroid refers to the thyroid gland, thyroid hormones. So when we put that together, we get an underactive thyroid gland. So if we move to the next slide, we have the definitions of all these terms. Yeah, so hypertension, we said, was loss of pressure. So this is a long-term force of the blood against your arterioles, and it becomes high to the point where it eventually causes heart problems such as heart diseases. Hyperlipidemia, high levels of fat in the blood. It can deposit in blood vessels, walls, and restrict blood flow. And it also poses a risk for heart attacks and strokes. Fibromyalgia is a widespread musculoskeletal pain accompanied by symptoms like fatigue, sleep, memory, and mood issues. And lastly, hypothyroidism is the underactive thyroid gland. So this is when there's limited production of thyroid hormone. And the thyroid hormone is crucial in your metabolism, your heart rate, your body temperature. We can move on to the next slide. All right, so we're not going to go ahead and decode diabetes, but for osteoarthritis, we can split it into osteo, arthro, and itis. So does anyone know what osteo means? Bone. Yeah. Yes, good job. Arthro? Joint. And itis.
Inflammation or infection.
Exactly, good job. So when we put that together, we get inflammation of the bones and joints. Next slide. Yeah, so as you can see, osteoarthritis is the inflammation of the flexible tissue known as joints of the bone. You can have joint pain in your hands, neck, lower back, knees, or hips. And diabetes is when you have abnormally high levels of glucose in the blood. So does anyone know the difference between type 1 and type 2 diabetes?
We have a bunch of hands up. I can call on some people if you'd like.
Sure.
Okay,
Thank
Gabriella.
I might have them switched, but I think type 1 diabetes is when your body doesn't produce enough insulin. And then type 2 is when you take so much glucose that your body can't keep up with the insulin it normally produces.
Yeah, so type 1 diabetes is when your body can't produce enough insulin, and this is a genetic condition. Whereas type 2 diabetes is when your body builds up a resistance to insulin. So more medication is needed to achieve those target glucose levels. And type 2 is lifestyle related and it develops over time. Does anyone know what gestational diabetes is or which group of people it impacts?
Pregnant?
Yes, pregnant folks. So we can move on to the next slide. All right, so now we're going to be going ahead into our mock diagnosis lab. As we're going over case studies, we kindly ask that you hold on to your predictions until we put you into breakout rooms. So our first case, a 21-year-old woman presents to the emergency room with right lower quadrant pain of 12 hours duration. So what does right lower quadrant mean? Let's go to the next slide. In order to understand that, let's first take a look of anatomical position. So anatomical position refers to the standardized posture of the body. It's a uniform position around the world, and it helps to describe human anatomy in a clear and consistent way. So feel free to stand up and practice this as I'm explaining it, but in standard anatomical position, the body is standing upright, you're facing forward with your legs slightly apart, and your feet and palms are facing forward. So there are a couple of different views related to anatomical position. Anterior refers to the front side of your body, and posterior, or the dorsal view, refers to the back side of your body. So your kneecap, for example, would be located on the anterior side of your body, whereas your shoulder blades would be located on the posterior side of your body. Medial, if you take a look at the diagram, there is a red midline running down the center of your body. So medial is towards the midline of your body, and lateral is away from the midline of your body. Superior refers to the upper end or towards your head, and interior refers to the lower end. Inferior, refers to the lower end and away from your head. And the last set is proximal and distal. We use this to describe structures that have a beginning and an end, such as your limbs. So proximal refers to towards the point of attachment, whereas distal refers to away from the point of attachment. Okay, so if you look at the diagram to the left, what do you notice that seems odd about this diagram?
We have a hand raised. Rowan?
Yeah, go ahead.
Okay, I guess that all medical diagrams are the opposite of our hands. I mean, when I see like my left hand, it's in the right hand of the body.
Yes,
the
that's
opposite of
exactly
me.
right. Yeah, good job. So if you look at the diagram, you may have noticed that the right side and the left side are actually switched around. And this is because the diagram is referencing anatomical right and anatomical left. So anatomical right, imagine you are the patient. It's the right side of the patient in anatomical position, meaning for a viewer, this would be the left side. Anatomical left is the left side of the patient in anatomical position, so the viewer is right. So essentially all you have to know is that the right and left are switched. On the diagram to the right, we have the quadrants of the abdomen. So on the very right are the abdominal pelvic quadrants. We have the right upper quadrant, the right lower quadrant, the left upper quadrant, and the left lower quadrant. And to the left of that image, it is further divided into the abdominopelvic regions. And if we go to another slide, yeah, so these are just all the different organs in each of the quadrants. We'll be focusing on the right lower quadrant. So that includes your cecum, parts of the intestines, the right ureter, the appendix. And on the next slide, we have a close-up view of the different organs in the right lower quadrant. Yeah. So let's move on to the symptoms of this patient. They have a swollen and tender belly. They had pain in their lower right belly, and it's moving down towards the navel. On a Wong-Baker scale, which is basically the standardized pain scale, the patient rated their pain a 10 out of 10. They have severe cramps, high fever, and nausea and vomiting. And I'll give you guys just a few seconds to quickly write that down. Okay, we can move on to the next slide. So, past medical history and medications. 3 years ago, this patient had an aortic valve repair. Their weight and height are in relatively normal range. They have no medications, and their blood pressure and oxygen levels are also in a normal range. Next slide. So, Dr. Owen Hunt ordered a few tests, starting with a urine sample to check for urinary tract infections, a CT scan to examine the abdomen, and a blood test. So what did we find out? Okay, so when the blood test came back, we found that there was an elevated white blood cell count. So what could this indicate? Again, I just want make sure you guys hold on to your predictions. We're going to be going into breakout rooms in a few seconds. Yes, exactly, infection. So the urine samples came out normal, and the CT scan pictures showed unusual inflammation. And on the next slide, we have a close-up of that. Yeah, so there's inflammation near the lower right side of the abdomen. The last scan is a picture of a normal abdomen, and the very right one is just a zoomed in picture of the middle scan. So we narrowed it down to 4 possible diagnoses, which are, next slide, please. A urinary tract infection, pregnancy, kidney stones, or appendicitis. So you guys are going to be going into breakout rooms where you'll have about 2 to 3 minutes just to discuss what your predictions are for the diagnosis and also come up with a possible treatment plan. Next slide. Yes. So we ask that you have one of your team members just write down your answer, and when we return from the breakout rooms, we will share our answers together.
Awesome. Okay, I'm going to stop sharing my screen. We might only have time to do breakout rooms for this one, and then perhaps we could keep, do you want to do the other ones where like people like respond in the chat or something after a minute or two?
Yeah, sure.
Okay, sounds great. So I'll split everyone up into breakout rooms for now, and then you'll have a couple minutes to discuss. Okay, I'll create 7 and then, okay, they should all be open now, so you can go and join them. It says there are 7 minutes there, but we're going to close them after like 1 or 2 minutes.
Oh, can I ask a question?
Go for it.
What's going on? I cannot remember.
So right now we have breakout rooms open where you can discuss and diagnose the case study that we were just talking about.
Has everyone returned back from the breakout rooms, Davina?
Everyone will be back guaranteed in like 5 seconds.
Okay.
Okay. I think they're all coming back now.
Yeah.
So we'll give everybody a sec to like rejoin. Right.
All right, so as everyone is returning back to the main room, does anyone want to raise their hand and give a shot on what their diagnosis is? And maybe even propose a treatment plan?
All right, we have tons of people with their hands up.
Okay, Ilias?
So I was with Gabriela, I think. So I think we decide it's like appendicitis because the urinary tests were normal. It's not pregnancy because I think the blood pressure is high when you are when the female is pregnant. It has like to provide baby with more blood, and I think that's it. So Gabriela can add something if she has something because she was with me in the same room.
Yeah, go ahead.
Oh, thank you. Yeah, so we did just said appendicitis because of what he said. That also because like when we were looking at the root words, itis would have meant inflammation, and we didn't think it would be urinary tract infection because the urine sample came out as normal. So we ruled that one out. And we also ruled pregnancy out because like as he mentioned, the blood pressure was normal.
Exactly, good job. I love how you really broke the word down into the root words as well and determined that it had to do with inflammation. So does anyone have any ideas of how we could treat appendicitis? Sarah?
I believe one treatment is, which is like the most used, is appendectomy. Like we just perform surgery to get rid of the appendix. But it should come, like it comes with risks because appendicitis causes like we have to drain what was it called? The abscess, I guess, because it forms like a fluid. So we have to drain it first before surgery. So yes, that's one treatment plan.
All right, great job, everyone. The correct answer is appendicitis. So you guys are all doing amazing. As Davina is just going to pull up this presentation, an appendectomy, as Sarah mentioned, is essentially what she said. When an appendicitis is formed, the mesoappendix is divided, it's tied off, and then the appendix is finally cut off. And then the stump can be inverted by using a purse string suture. So moving on to the next case. Yeah, and we covered that. Here are just the steps of an appendectomy that we just went over. All right, so a 20-year-old man is admitted to a physician's office for a possible metabolic disorder. His symptoms were he was very thirsty in recent months, frequent urination in recent months. He was collapsing at work. He had severe flu-like symptoms, and there's no evidence of viral or bacterial infections. Next slide. So, Dr. Mark Sloan ordered a blood glucose level test as well as an insulin lab test. And when the results came back, we found that the blood glucose level was at 520. So you guys can type in the chat if you think that this is higher than average, average, or below average. And as for the insulin test, we found out that there was minimal insulin production. Yes, exactly, it was higher. So moving on to the possible diagnoses. Type 1 diabetes, type 2 diabetes, hypothyroidism, and hyperthyroidism. So I think the answer, it might be a bit easier than the previous one, but in terms of how we would distinguish between type 1 and type 2 diabetes, next slide. Yes, so the key was that the test results said that there is minimum insulin production. We're not going to do breakout rooms for this one, so we can go over to the next slide. Yes, so minimum insulin production is a key indicator of type 1 diabetes because we're not producing enough insulin on your own. And since there is no resistance, we can also rule out type 2 diabetes. So in terms of treatment, there's insulin treatment. You can use a glucometer to measure your levels of insulin, and regular diet and exercise can also help. Okay, moving on to case study number 3. Susan, a 30-year-old woman, is admitted to the hospital and she's complaining of headaches, shortness of breath, and dizziness. Next slide. Her following symptoms were she had headaches, a shortness of breath, flushing, dizziness, chest pain, and visual changes. Next slide. Yes, so Dr. Miranda Bailey ordered the following tests: a urinalysis, a blood cell count, an ECG, and a physical exam. And from those results, what did she find out? Yeah, so we had a blood pressure. The systolic was 135, and the diastolic was 85. The urinalysis showed high levels of blood in the urine. Yeah, so we're going to skip breakout rooms for this one. So the final diagnosis was she had hypertension, which we already discussed earlier. The treatment options include a healthy lifestyle, so regular exercise, healthy diet, and she could also prescribe medicines such as beta blockers or alpha antagonists, and these drugs basically reduce blood pressure by making the heartbeat slower, and with less force as well. All right, so that concludes the medical diagnosis. Oh, sorry, did I make a mistake?
I think you're good. Do you want me to stop sharing?
Yes. Can we go to the medical practices first?
Yes.
Okay, I think there might have been an extra copy of the slide over there. So moving on to medical practices. The first category are laboratory tests. So the first one is a urinalysis. We went over this, so just to briefly explain, a urinalysis analyzes everything from the appearance, the concentration, to the content of urine. In addition, urinalysis is also used to screen for diseases such as liver disease, kidney disease, and diabetes, or to diagnose urinary tract infections. So for example, an increased level of proteins in urine could be an indicator of kidney disease. The presence of glucose could indicate elevated blood sugars, which means diabetes, and the presence of nitrates could also mean that there is a UTI. And blood tests, Ahmad talked a lot about blood yesterday. So just to briefly go over common blood count, it's a very common type of blood test that's frequently performed during your routine checkups. So this includes assessing your red blood cells, your white blood cell levels, platelet levels, and hemoglobin. The next set of tests are imaging tests. So an imaging test produces a detailed picture of different areas in your body, and they use different forms of energy, such as X-rays, sound waves, or radio waves. So a very common type of imaging test is an ultrasound, also known as sonography. This is a non-invasive imaging method that uses high-intensity sound waves to create an image or a sonogram of structures within your body, such as internal organs or soft tissues. And generally, when people think of ultrasounds, they're usually associated with pregnancies. But while they are used to observe the uterus and ovaries, there are several other uses of ultrasounds. For example, they're used to diagnose different diseases. They're used to examine breast lumps or check the thyroid gland. Ultrasounds are also very useful to guide needles during certain procedures. An example is amniocentesis, which is a procedure to remove amniotic fluid. Using an ultrasound is really crucial in order to guide the needle. Another imaging test that's pretty common is a mammography. This is essentially an X-ray imaging test that's used to detect cancer in early stages and other breast diseases. So on a film, areas of dense tissues such as fat would appear translucent, whereas areas of low density tissues would appear translucent, and areas of dense tissue would appear more whiter and opaque. And during a mammography, radiologists examine everything from size to shape to the edges of high density regions. And the last imaging test we're going to go over is an MRI, which is a magnetic resonance imaging. Yes. So an electromagnet is used to generate a strong magnetic field. And in addition to radio waves, it produces a very detailed 3D internal image. And last but not least, an endoscopy. So an endoscopy is a procedure where a long flexible tube with a camera attached is inserted down your throat and into your esophagus. And it allows the doctor to view your digestive tract on a color TV monitor. It's often performed when a patient has stomach pain, an ulcer, maybe bleeding in the digestive tract. One type of endoscopy is a colonoscopy. This is when the doctor uses an endoscope to look inside the large intestine. And a bronchoscopy is when the doctor looks at airways using a thin light tube. This is also done when there's, changes in bowel activity would be for colonoscopy, but yeah, a bronchoscopy is inserted through the nose and the mouth, the trachea, and finally into the airways. And that concludes the workshop for today. I know we definitely went over time with this, but I guess if you guys have questions, maybe we can go over them after today's meeting.
Awesome. Thank you so much, Tanuja, for that awesome workshop. We really appreciate it. It was awesome, and we really enjoyed learning about all of the different medical practices, and it was actually very engaging to go through some of the cases too. A note about the ultrasound: I actually didn't know until recently that you can get an ultrasound done for different things too. So I recently tore 2 ligaments in my ankle, and one of the tests I had to get done was an ultrasound of my ankle, and I was confused. I was like, what do you mean I have to get an ultrasound done for my ankle? But yes, they do use it for a ton of different medical cases. So yeah, it's very interesting that all these tools are so versatile. Okay, so we don't have time to do all of the debate and discussion topics that we wanted to talk about today, but I think we'll have time for at least one. So I know that we posted this in our Google Drive, and then we also sent it out as homework. But if you haven't had a chance to read through some of our discussion topics for today, you can open the doc that I just sent in the chat. Elias, do you have a question? or is it like a hand from before?
Actually, it's like about diagnostic. I don't know why, like it was type 1 diet. It was like the diabetes. I don't know how to pronounce it in English, but it was type 1. Why it wasn't like type 2?
Yeah, okay. So did you want to answer that one?
Sorry, I didn't get the question. Would you mind repeating it?
It's basically
Go to hell.
type 1 diabetes and not type 2.
Are you asking me?
Yeah.
So the difference between type 1 and type 2 diabetes. So type 1 diabetes is when there's minimal insulin production, and this is inherited genetically. Whereas type 2 diabetes it's related to your lifestyle and it develops over time. And this is when your body has a resistance to insulin.
Thank you. Yeah.
Awesome. So I sent the doc in the chat, and would you all prefer that we discuss topic 1 here as a big group, or would you prefer to be split up into breakout rooms? You can respond in the chat. So if you haven't had a chance to read over the doc yet, the first thing that we'll be talking about is healthcare for all, and it's specifically based on an American system, but it could be implemented anywhere. Just the pros and cons of implementing a healthcare system where everybody gets coverage. Again, please respond in the chat and let us know if you prefer to discuss it in a big group or if you'd prefer to do breakout rooms. Okay, I have 3 people saying big group. Okay, a lot of people are saying big group. Okay, so we'll do the big group. You don't have to raise your hands for this or anything. You can just unmute and speak because this is more of a discussion and not as much of like a raise your hand and answer kind of thing. So you don't have to raise your hand for anything. You can just go ahead and discuss, and then we'll probably discuss this for maybe 5 or 6 minutes, and then we'll wrap up the session and take another group picture and then release the homework. Okay, so anyone is more than welcome to get started. We'll try to participate as little as possible so you all have the chance to discuss with each other as much as you can. But anyone that has an opinion on this is welcome to just pipe up. Does anyone want to get started?
Okay, hi. Well, I was really interested in topic 3, but I think we got topic 1, right? Medical health coverage for all. Okay. I think it can be harder to be implemented in other countries. Really, it's really hard actually, because most of really medical health coverage is expensive to implement, and medical terms and hospitals have really machines that are really expensive. So why do you think it's a good idea to be implemented? Okay, do everyone think that in the future will be some influencers that can implement sort of this program?
Yeah, does anyone have anything else to add? If you have your hand up or anything, you can just go ahead and speak.
Should we talk about the first one or like the one that we choose?
We're talking about the first one right now, but if people would prefer to talk about a different one, we can switch topics. That's totally okay.
Okay, thank you.
Yeah, no worries. Will people prefer a different topic?
I think so. I prefer topic 3 because I feel like topic 1 is really related to economics and entrepreneuring, not just medical terms, I guess. Or what do you think?
Yeah, that's totally fine. We included topic 1 because it's good to be aware of like global politics too and how it influences medicine. But if you all want to like switch over to topic 3, go for it.
Well,
Yeah, I think if we choose another topic, it will be better. As topic 1 got a lot of difficulties in understanding the ratio between the the total cost of the medical coverage and the facilities and that it presents to the one who subscribe in it or something like that.
Yeah, sure. Okay, so we can move to, is everyone okay with topic 3? It just seems, I'm just going based off of what people are saying. Yeah, okay, so you can talk about animal experimentation. And I guess we can start off with just a question that I'll ask everybody. So do you agree that animals should be used in experimentation? Are there any good alternatives, pros and cons, etc.?
I believe animal experimentation is necessary to a certain extent, but humans do really abuse this like process. And I don't know, but I believe like the medicine has laws concerning what animals you can experiment on and what animals you should refrain from experimenting on. And I guess it depends on a great extent on the size of the species. And, and like if they're endangered, of course, you cannot perform any experimentation on that.
okay, I think so, but we all should agree that most of our most of the inventions and really huge medical inventions was based on animal experience at first, even if it most of the time sounds aggressive, but I think it's really important to use it. I mean, you can experience in a rat, but you can't experience in a human. That would be a much bigger problem.
I actually do agree with Rowan. Like, we can't just stop using animals for experiments. Like, we don't really have much of an alternative. So, animals are the best option out there. So, maybe we shouldn't abuse the whole idea, but still, we can't just stop using it.
Actually, I do support.
Okay.
I just support it because, but in not an abusive way, because we are humans and we can't like test medicine or something like that directly in humans because it will harm the human or that person. So the animals are like the one that we can practice in or test our medicines. But I think that we should limit it in some spices, not like we shouldn't do this experiment on like rare animals such as panda or something like that. It should be in like the animals that are frequent, like, but it's not, it's necessary because like it's a part of the like how the medicine is produced, so it should like pass the process.
Okay, but I think we can eliminate experiences in animals by using alternatives in the lab. There are many choices that we can do today, like experimenting in vitro. I guess I'm not sure about the naming of the things in the lab, but I think there are in vitro and in vivo and silico. And some of these are experiences on living cells, not animals, not a living organism, um, just like a rat living, no, just cells and things. And we can predict the analytics and apply it in a bigger way. But we can't publish anything, or we can't experiment anything in humans before even use it in a living organism. These things or alternatives will be just to eliminate the experiments on animals. But we can't depend on it.
Actually, I think that animal experimenting is like cruel, but it's really necessary. But we can shift experimenting with bacterial culture and stem cells. That will be much better. But I also think that experimenting with animal is more accurate. But I think in the future we can develop it and it will be much better because all animals are equal and I think that they are equal to human and we cannot discriminate them.
I agree to a certain extent, like advancements in the field of medicine will allow us to kind of refrain from excessive animal experimentation and move on to like more sustainable ways of experimenting. However, I think the issue here is that it wouldn't be an issue that we're discussing right now if it wasn't like extremely excessive and abusive. As someone who has been part of an organization who advocated for animal rights, you cannot believe the amount of abuse scientists would go. Sometimes they would take it really too far at times. And like after all, animals like they have the right to live and just live on this planet just like we do. This is why I think we should advocate for animals' rights.
I totally agree with you. I just want to know that if there's any associations or something like that that try to preserve the animal rights and decrease the usage of them in the animal experiment.
Sure. I was part of an organization called PETA. It's PETA, and it advocates for animals' rights, especially in like concerning animal experimentation. You can check it out if you're interested.
Okay, that's great.
I also agree because actually we are not the center of the universe and everything wasn't created for our good. And I think they have also right to live and we cannot use them like tools. They are living beings.
Even that is normal because of the ecosystem. Without animals, we cannot live. Also, if we don't eat chicken or meat, I'm talking in general.
Yeah. Okay, something got out of my head. If you should let me just think of it. We should make rules of using animal species because maybe if they experiment in a species that is in a biological cycle, we may make a huge difference in the cycle of biological living organisms. Understand what I mean? Because maybe if we just killed most of the butterflies, we may cause a bigger problem in the biological living organisms around us.
You mean to protect them from extinction?
Not just extinction, but when we decrease the number of a living organism in an environment, the environment will be affected in the opposite direction. It's a cycle when any species can affect the whole cycle of biological species around.
Yeah, that will affect all of us. The two position.
I also agree. We cannot say that animal is too tiny as it does not affect the ecosystem and we can do whatever we want with it. Every creature affects the ecosystem even bacteria, viruses, any creature affects the ecosystem.
But I think sometimes we need to use the animals as doing these experiments virtually will not give us the right results for it. So I think sometimes we really need to use these animals, and of course
I have one
preserve
question.
their rights.
Can I ask?
Of course, you can.
Okay, I want to know when will we get the certificate?
Can I ask
After we
you-
finish.
Yeah, you can ask me at the end of the session.
Okay, tamam.
Yeah, no worries. Okay, I think with that, we'll wrap up our discussion for today. Awesome job discussing, everybody. And then for those of you that wanted more information about the organization that one of you was talking about, I just sent the name of it in the chat. It's called PETA, P-E-T-A. So you can go ahead and check that out if that's something that's interesting to you. So for right now, I'm going to send the link for the homework in the chat. Don't worry if you miss it here. It's going to be sent out on Slack. It's going to be sent out to your emails. We'll post a reminder about it. Again, a reminder, it's due a week from today. So today is Saturday. It'll be due next Saturday at 11:59 p.m. So please make sure to fill out the homework because we only calculate certificate eligibilities for people that fill out the homework. Homework is required in addition to attending the 2 sessions. So you can go ahead and fill that out. And we also had some requests for people that missed the group picture at the beginning. So if you'd like to turn your camera on now, I'll take another one for those of you that missed it. Just because I know I got like a couple messages from people and I don't want you to miss out. So if you missed the group picture, or even if you didn't miss it and you'd like to turn your cameras on too, you're more than welcome to. I'll just take another one and this will be sent out as well. So go ahead, feel free to turn your cameras on. Again, not at all required. Just wanting to do this for the people that missed out. And I'll wait a minute before I take it to make sure I don't miss anybody this time. But this will be the last chance for a group picture, just because it's our last session today. Yeah, so somebody asks, is there a session tomorrow? No, this wraps up our winter camp. So our winter camp is usually 2 days. We extended it to 3 this year, so you could just have more of a learning experience. But this wraps up our entire winter camp, so there won't be any more sessions after this. But if you want to apply to our summer program, applications for that will come out in a month or 2, and you're more than welcome to go ahead and apply to that. We really encourage you to apply, whether you're national or international. We have cohorts dedicated for both groups of participants. And we really encourage that experience for everybody as well. Okay. Does anybody need me to wait?
I think we are sorry because we want to see you tomorrow. I mean, we used to have you at night, like every day. So that was really lovely. Okay.
Yeah, I totally get it. Like you're used to seeing all of us like every day for the past couple days. All right. And yeah, you'll all get like reminders. We'll email everybody when the summer program comes out, encouraging you to apply. Homework is due a week from Saturday. Okay. I don't see anybody saying that they would like us to wait for them. So I'm gonna go ahead and take the picture now. If people don't have any other questions. Okay. Hopefully I've gotten everybody that missed the picture the first time and some other people that just want to be in another picture. Okay. Alrighty, so I'll give everybody a countdown, okay? Okay, ready? 3, 2, 1.
Can you wait for 1 second?
Yeah, sure. Okay, I took some. I'll wait another second. So please try to turn your cameras on quickly so we can take the picture, but I'll wait another little bit for people to be ready. It's so lovely to see all of you. You all look great. Okay, I see your camera on. All right, I'm gonna take another picture. Okay, ready? 3, 2, 1. Okay, we're all good. So that wraps up our winter camp. We're really happy that you joined us this winter. We weren't anticipating to get this many participants, but we're so happy you joined us. If you have to head out now, you're more than welcome to. We just wanted to say thank you for joining us because programs like this would not be possible without all of you coming here and supporting us and joining us. And we're really grateful that you decided to come check us out and come apply to a program. We really, really hope it was a worthwhile experience. We hope you learned something and felt encouraged in pursuing a career in medicine or STEM, because I know that it can sometimes get the rep of being a really competitive field, and we just want to make a space that is less competitive and more supportive. So we're really, really grateful that you joined us this winter, and we hope to see you again. I don't want this to be the last time that I see any of you all. You're more than welcome to keep in touch. You can send me a message whenever you want. Send us an email. I'm more active on Slack. But yeah, it was really lovely getting to meet you all and getting to hear from you. You all are amazing people, and I have no doubt that the fields that you go into will be made better because you're all going to go